started because I don't waste any time. And I believe we have CME for this, correct, Sue? So for those of you who want CME, the slides will be at the end. Is that correct, Sue?
I will actually put it up at the end, and I also will send it out via email to everyone.
Thanks, Sue. So I just want to, first of all, thank Drs. Emily Bale and Quiva Duffy, who, as physicians in the Department of Anesthesiology and Critical Care, have really reached beyond their incredible accomplishments in research and clinical service to really look at some issues that have such a huge impact on the careers of women and also of their partners. So I would like them to introduce themselves in the context of how they came to work on this project, and I will now turn it over to them.
Thanks, Lucy. I was really grateful that we can present here, and this is an ongoing project. And some of you might have heard there, we have Dr. Joan Glutch from the dental school on the line, and we've got some of our summer dental students and medical students that have been helping with this work. And this is very much a project that has been born out of personal experience from both Dr. Vale and myself, coming from very different backgrounds. Dr. Emily Vale from Minnesota, pictured here at the flower show last year when I was 2 weeks postpartum. She went to Columbia and to UT San Antonio and found herself in Penn and starting clinically at the same day as I did. She's been the co-founder of a tele-mentoring group called Raise Echo, which is a resource, advice, insight, support, and empowerment program for early career women in medicine. And that's a monthly meeting. And if anyone wants information on it, please ask Emily about it, because there's a link, and it's, you know, fantastic resource again for sharing information. I, on the other hand, came from Ireland in the middle of a pandemic with an 18-month-old child, pregnant, starting on faculty, learning a new healthcare system, both as an anesthesiologist, but also from the standpoint of being pregnant and trying to figure out resources, advice, how do I navigate this system? And so that is how we have been led to talk about this topic today of how do you support pregnancy, parental leave, return to work within our faculty, and also ensure that you've got career progression along the way. So we're going to talk today about a framework that we kind of created for understanding this as a problem, and look at the role of policies and guidelines and how they can help. We're going to present a review of our narrative review, the results of this, and look at the results of a faculty leadership survey that we've done throughout Penn to find out what is available. We're going to share and discuss some personal experiences throughout, and also look at available resources at the end of this session as well. Now, this is a huge undertaking, both in scope and depth. So we want to state from the very beginning that we aren't aiming to cover everything or provide a very comprehensive set of resources, but we will be able to help point towards where things are and how we can improve. So in terms of background, the short kind of concept of this is that women in academia is not a new problem. The attrition has been going on for a very long time. In the early 1900s, women were seen as a very poor investment in medicine because their male counterparts, because they were more likely to abandon the medical profession in favor of raising a family. And between 1970 and 1990, you've seen this huge change in medicine where the demographic really was changed. So it was like went from 10% in 1972 up to 42% in 1999. But the medical work culture has always prioritized workforce needs over personal needs. And despite this increasing number of women in medicine, there hasn't been a change in the system or the supports around it. And when you start looking at, you know, defining the scope of the problem and looking at the physician parent, they're older at the age of the first child. There's increased rates of infertility, of assisted reproduction, of miscarriage and preterm birth. You've got higher obstetric complications. They take shorter parental leave. Despite initially having high rates of breastfeeding, most women, when they go back to work postpartum, will stop breastfeeding. And this in turn results in burnout, depression, because they haven't reached those goals or those milestones they had set for themselves. They still remain the primary caregiver. Their career is impacted and they face a reduced in income. And a great example of all of this is really enshrined in the global pandemic, the COVID-19 pandemic, where there was an increased rate of publications over this time frame, but there was a lower rate of female first authors. So really, how do we start adapting and looking at the workplace and creating a more an environment that's going to accommodate and modify to allow the physician parent to thrive? And when you look at same-sex couples, non-binary parents, adoptive, foster parents, there's even less research and less support. So creating a family should not be a barrier to becoming an excellent physician. And when you start assessing supports for faculty during these life transitions, it's not an easy task. It doesn't impact all workforces, and it's going to impact everyone very differently across divisions and departments. Particularly now you've got a lot more dual career couples, and that creates a rising expectation that both parents are involved in childcare. So you've got increased father involvement in childcare, which makes work-life balance an even bigger challenge for a growing proportion of men. So you need to start looking at work-life policies that are really going to impact both men and women to prevent turnover. But when we start looking at these gender disparities, there's pre-existing stereotypical gender norms that already arise. And your intensive medical training coincides with the optimal biological time to have a family. So you see that women are more likely to delay childbearing. They have higher rates of infertility. The really interesting fact that female urologists were found to have doubled the infertility rates of the national average. When you look at pregnancy at an unmodified schedule, most women in medicine are working unmodified schedules right up to the day of delivery. And the idea of asking for accommodation is perceived as if it's going to come across negatively. And that is a huge point. In terms of family life, female surgeons are more likely to be the primary caregiver compared to their male counterparts, but female surgeons rely on third-party caregivers, while male surgeons report having a spouse at home as a main caregiver. Again, with your career impact, you're less likely to be in a leadership role. Your career advancement is slower than men. And again, you've got that conflict with your partner's career. So becoming a physician parent can be very isolating, very lonely. It can be difficult to find people at work who understand your position. There's a huge negative perception, and then one that is often not spoken about. And often, rather than accommodating and modifying the workload, the stigma is resulting in women not advancing their careers and also leaving the workforce. And I'm sure there's many people on the line today who can resonate with some of these quotes. Most often, these are asked to the woman, they're the pregnant person who's about to go out and leave, and well, what are you going to do about childcare? And quite often they're not asked to the father. So in order to start looking at it, and how can we change, how can we adapt, how we can create some guidelines around it, we need to look a little bit at the history of what's been happening. So in terms of change, it's been very slow. Back in 1988, there was numerous articles published recognizing the need for maternity leave policy. This is after that huge demographic change and an increased number of women entering medical school. The 1990s were described as a family-friendly decade. Interesting to note, the American College of Physicians recommend parents be the primary caregiver for the first 4 months after delivery. In medicine, we don't treat our physicians with the same luxury. ACGME have no formal policy, but mandate institutional policies. And it's only in 2022 that they've required all programs to offer 6 weeks of paid leave for all residents and fellows. So it's very difficult, looking at each of these organizations and saying, okay, create a policy that's going to cover a huge range of people. But what can be done is that the frameworks can be developed, which then individual divisions can build their own guidelines based on the unique requirements. So it's really important that we have policies in place that need to be flexible. Flexibility is a huge part of being a physician parent, particularly at these life transitions. And policies play a really pivotal role in both the psychological and physical well-being of mothers and children, as well as fathers. Another key point to note is that also academic faculty often underutilize existing policies. They can be difficult to trawl through to find that exact piece that, is important to you, that is going to be that piece of information that you need. And also, if you don't have supportive supervisors, or the workplace culture isn't there and it's inflexible, these can be really huge barriers to policies being put in place. In terms of some of the literature out there, there's on faculty parental leave policies. There was a report in 2020 that looked at the US News and World Report, looked at the 87 medical schools and found that 63 of them had paid leave for birth mothers, but 40% had no adoptive paid leave and 74% had no foster parent leave. Higher ranking schools were more likely to offer 12 weeks of paid leave. Another study looked at the 10 big conference universities, looking at the most flexible work-life policies, and it found that Michigan State came out at best. But even having these policies in place, all of these two studies just look at having a policy. They didn't look at adoption or implementation, which is really, really essential. And so there's different domains that really need to be covered when you're looking at policies to cover these timeframes. So family leave, part-time, lactation policies. And we have a lot of these here at Penn, and we can talk about them in a little while again. Northwestern have a fantastic policy and really should be commended, called the Wellness and Work-Life Policy, which looks at managing the transition of parenthood. So on that return to work, how do you integrate your career in academics, on faculty, as well as your parenting career? This work-life integration is so important, and having resources available for these is really, really essential. There's a lot of ways in which guidelines have been shared. University of Michigan, who is actually noted in a review of the Big Ten conference universities as having demonstrated the most change over 10 years in implementing and developing policies. They have a safe and supportive pregnancy policy that has been shared across social media. These types of policies demonstrate reduced absences related to illness and lower attrition rate when they're implemented. But just because you have a policy in place doesn't always mean that it's gonna solve the problem straight away. There's multiple barriers to career progression, and some of them are very difficult to change, particularly in terms of advancement. Having board certifications at one set time in a year can often be a hard stop for many fellows leaving training before they can go on to get their job. So it's important as well that we have role models, mentors who have been through these life transitions and are able to offer advice and demonstrate, okay, this is how you do it. And it has been a great resource to have focus to have a lot of these talks and to host different seminars on these subjects. So to try and look at this a little more cohesively, we created this conceptual model to simplify all the important elements that should be really considered when supporting faculty and ensuring retention and academic progression. So this is a human-centered design, which we've broken up into a work system, work processes, and outcome, with the outcome being retaining your faculty. There's a constant circle going on here that you have to adapt, you have to learn, you have to improve. But we can look at the creation of guidelines and policies by designing and improving some of these elements. So we're going to look at some of these a little bit closer. And obviously with each of these, there's barriers and facilitators to how we can adopt policy and put them into place. So we have been looking at the literature over the last number of months and kind of pulling out the big things that have come across in a number of the articles published. And a huge barrier straight away is the physiological nature of pregnancy, and often one that is forgotten. One of my favorite kind of anecdotes is being asked to cover an operating room when I was 35 weeks pregnant. That was so small that I wasn't actually able to physically fit between the stretcher and between the surgical equipment. And so even these very basic concepts that we have to adapt our policies and adapt where staff can actually work due to these natures of pregnancy. Running across the hospital when you're in the third trimester to an arrest call is not a situation that the vast majority of pregnant women can do. So taking some of these barriers in place and adapting them into local policy is really, really important. The big thing that we need to always keep in focus is that women want to remain in the workplace. They want to be accommodated, want to have their schedule modified to allow them to continue working. There is a huge satisfaction felt across these life transitions, and people would repeat those choices again and again if given the chance again, because despite all the barriers, they felt it was rewarding. In terms of looking at the organization, in terms of what elements are there, the lack of policies, lack of guidelines is really, really highlighted as one of the biggest barriers. Culture, stigma, hierarchy, people feeling unsafe speaking up, having to ask for help again and again, having to ask the coordinator to help cover a break for lactation. These are all things that we can try and work on by creating policies, by adapting, and by making it easier for people to speak out and say, hey, this is what I need. How can we fit it in? Having advisory groups, having community groups together to share examples is one way we can, that's helpful to help change these scenarios. Adapting the workplace is also really, really important. The ergonomics, particularly during pregnancy, of having to push heavy stretchers, lift patients, radiation. There was a lot of things that can be done quite simply. Also looking at telemedicine, increasing some of the outpatient work. There's different adaptations that can be made. And it's really important that you keep kind of going back to those words of accommodation for clinical schedules and looking at accommodation and modification rather than saying that they're looking for a reduction in workload, because really people want to continue working. They want to continue their schedule as they've been going. So it's all of these is just adapting. Again, with looking at kind of some of the tasks, or view-based incomes is a huge thing. Trying to reduce having a reduction made because of taking breaks for lactation or because of maternity leave can really hinder their future access to RVU-based times. So taking them into account and changing it, and we're going to talk a few minutes time about some of the changes that have taken place in Penn to target some of these changes. And then again, tools, where you look at childcare, is the number one stressor for parents. At Penn, there is a certain number of childcare options, including one daycare close to HUP that opens at 6:30, which is really, really important. because having that flexibility around the workday is essential for faculty. And these are things that need to be built in. Similarly, having conferences online rather than in person are really helpful, because it can be often very difficult for parents to get children to a daycare or to school and get to work, and then add in a morning conference at 6:30 can be an incredibly huge stress. So when we start looking at this approach, we can kind of put together all of these tools, the organization, the physical environment, and kind of start seeing, okay, what areas can we target here? And then how do they play into the culture? How can we adapt and change the culture by adapting some of these elements? And then incorporating them into our local institutional policies or within our local leadership, but also within the legal framework. In the US, the USA is actually one of 7 countries in the United Nations that does not require employers to provide paid time off as new parents. There is certain exemptions in terms of states, New Jersey, California, Rhode Island, that have created some legal frameworks around this. But that kind of sets the tone for where we are currently at in terms of creating and implementing some of these changes. FMLA is available, and then within the Civil Rights Act and the Pregnancy Discrimination Act, which was added on in 1978, as well as the Education Amendment Act, gender discrimination is really looked at and treated within these laws. But then more recently, we have the Fair Labor Standards Act and the Pregnant Workers Fairness Act, which again looks at trying to improve accommodation. And it uses these words, reasonable accommodations, to change the workers' environment related to pregnancy, childbirth, or related medical conditions. So trying to ensure the environment is applicable for them to continue working. So how might policies actually facilitate into all this? Well, it's normalizing some of these accommodations that need to be made, making them spoken about, challenging that kind of concept of being a hidden curriculum about personal needs versus personal or professional responsibilities. So I'm going to hand over to Emily to talk a little bit more about exactly what we did in our narrative review and how we've can put these into place.
Thank you so much. I think if we've learned anything in this process is that we have a lot to learn. I'm going to present the results of our narrative review that we started talking about a little bit at the beginning of the presentation, and then follow that up with some information about the recent faculty leadership survey. So we initiated this review as part of the LDI Summer Students Program. So we worked with 2 students, Ria Patel and Shivani Iyer, who came to us from the School of Dental Medicine. And we asked them a pretty tall task. We asked them to help us understand which policies were available and impactful to help support women in academic anesthesia. They worked with 2 librarians in the School of at the dental and medical libraries, and came up with this. So we had an iterative process of examining available literature, started with a small number of search terms, and then quickly found out that within academic anesthesia, not much was available. When we further extended that search to dentistry and to medicine in general, we found a lot more. This is what this looks like. So from our initial search, we identified 580 studies. They were screened to a total of 371. 33 related to anesthesia, 31 to dentistry, and the majority related to other specialties. We focus primarily on anesthesia because that's what Quiva and I are, and dentistry because that's what Dr. Glutch, Shivani, Ria are training to become. Well, it's been really rewarding to compare and contrast different work environments, different considerations for practice styles we found the work to be very complementary. When I'm presenting next is what we found in the anesthesia literature. So across the resources that we identified, majority were web-based surveys or reviews, narrative or systematic. And on the figure here on the right, contrast those that mentioned the need for policies or identified policies with those who systematically examined the contents of policies or outcomes from policies. So even though it's something that's frequently acknowledged or identified as something as an important tool, the available literature to fully understand best practices, implementation, and outcomes is much more limited. So much more likely than finding policy based studies, we found examples like this. So this was a survey of members of the American Society of Anesthesiologists who were asked to comment on their own careers and their willingness to counsel medical students regarding a career in anesthesia. So two of the more impactful findings were, one, that about 10% of anesthesiologists would recommend against a career in anesthesiology due to obstacles with motherhood and job demands. They identified two factors that would make an anesthesiologist most likely to counsel a student against a career in anesthesiology. And that's when they had personal perceptions that their own work demands adversely affect the timing or the number of children that they were able to have. So this is a representative article. You note that it doesn't specifically invoke policies, but it does speak to the great risk of further attrition in our specialty. You may or may not be aware that only about 35% of American anesthesiologists are women, and that number has been fixed over decades. We've been far surpassed by surgical specialties that were traditionally considered more hostile to women. And when I go to, one of the reasons that I'm specifically interested in this work is when I go to national meetings, when I go to give oral board exams to new anesthesiologists, there's a demonstrable paucity of women, and something that I think suggests that our systems are not as robust as we hope to be able to make this a rewarding career for everyone. So in summary, across medical and dental specialties and disciplines, we found literature from countries across North America, Europe, and Asia, covering a wide variety of groups, from students to faculty. The majority of policy-focused articles focused on medical residents, and in part, this is because of a perception that in the US, residents are the group that may have the least amount of supports because of disproportionate financial and time constraints for their work. The majority, as I mentioned, examined personal experiences and professional impact, and the majority focused on pregnancy and lactation. So Ria and Shivani made this nice word cloud to identify some of the major themes that they identified, everything from leave to gender bias and equity, breastfeeding and lactation, focusing on workplace accommodations, as we've mentioned, both the presence and absence of policies and guidelines to help guide these practices, impacts on career advancement opportunities, the need for childcare and elder care options, processes for job reentry, and the constant tension between work and life balance. When the search was expanded to other specialties, we found additional great resources. Here on the left is a proposed set of policies for expectant surgeons that was recommended from the Academic Surgical Congress. Lots of very specialty-specific recommendations, both in terms of availability of policies, but how much call, when to take call, when should people be completely relieved of clinical duties. You'll note that this recommends a minimum of 8 weeks of paid leave and plan to restore referrals after return from parental leave, which is a specific concern for some specialties, but not others. On the right is an editorial published just this year, specifically, a few years ago, that specifically talks about recommended best practices for developing guidelines and supports for lactating residents. So I've alluded to this previously, but a lot of the available literature does not represent the full scope of caregiving experiences. It's mostly survey-based, single center, focusing on experiences and outcomes with all of the attendant limitations. Very few of these talked about policy implementations, and importantly, as Dr. Duffy said earlier, this is not examining the full breadth of experiences nor intersectional experiences. To try to understand what was happening at Penn, with the help of Focus and several other stakeholders, we then developed a leadership survey for faculty leaders. So trying to understand what individual departments and divisions understand and about available policies and how those policies inform their practice. So this survey was distributed to department chairs, vice chairs, and GME leaders over the early fall. We had a total of 12 responses from leaders in 10 unique departments or divisions. They answered separate questions about the availability and the applicability of these policies for residents and faculties in their department or division. Questions covered 4 different circumstances, from those undergoing fertility treatment to those who are pregnant or peripartum, those who are lactating, or those who have caregiving responsibilities, either elder care or care of young children. And simply were asked whether these policies were available and whether they knew there's policies available. Secondarily, we asked about the utility of the policy. So for these different circumstances, on a 4-point scale, whether the presence of a policy was useful to the leadership and to the department. Focusing first on faculty, so policies available for faculty were best represented for pregnancy and peripartum. And one survey respondent did invoke the CPUP guidelines that we'll share with you later. Similarly, some, although ideally would have perfect responses for all of these in terms of availability of policies, majority seem to be aware of policies for lactation, and about half with those for family and caregiving responsibilities. You'll note a theme here in the number of policies available or applicable to those undergoing fertility treatment. We'll talk about that a little bit more. When we compare this to responses for policies available to guide management care of residents, we found pretty similar patterns. You'll note that the residents are covered under a different set of rules, restrictions under the umbrella of the GME office, and they also have some resources that we'll share. Now, when we asked faculty leaders whether policies were important, defined however they wanted, for these 4 different conditions, the most common response that we saw for those undergoing fertility treatment was a neutral response. They couldn't say whether it was important or not important that these policies existed. There was a little bit more buy-in, the importance of these policies for the other circumstances listed here. And I would interpret this as those undergoing fertility treatment may be less visible to leaders, and therefore be less the perception that this is an important group, or being able to even identify who the stakeholders are in this group may be more difficult for leaders, or they may have less awareness about the specific logistical, physical considerations that are required for someone going through this treatment that may bias their answers. So we've mentioned this too, but there are certainly barriers to policies. And I want to emphasize that we know that they're not a panacea. So they're not always available, as I think we've demonstrated. They may not always be accessible, or maybe require frequent updating, or things that are less apparent to those looking for policies. The focus group and Dr. Bellini are going to have a follow-up session where they go through updates of all the policies that are applicable to Penn, so stay tuned for more information. But as I've illustrated, just the difference between resident policies and faculty policies, differences both in when and what applies to whom, differences in scope of those policies, as you've seen from the Northwestern work. Most importantly, and something that Dr. Duffy mentioned earlier that I want to emphasize, is that even if these policies are in place, even if these protections are in place, not everyone will use them, in part because of all the unmeasured, unforeseen potential complications and consequences. So as much as we can say you can have an extra year for advancement or promotion, if it's the last year that you're eligible for a certain grant or for other things, people may make calculated decisions about the risk benefit to their own lives and careers that can't be completely protected by policies. Something that can be very difficult is that in all of these circumstances, people have to self-identify and opt in. The policy doesn't apply or can't be applied if supervisors, leaders don't know that they are necessary for an individual. And sometimes the self-identification and opting in has to happen repeatedly. Every day there's a clinical assignment. Every time there's a clinical schedule made. Every time there's an opportunity for sponsorship or mentorship. An individual in one of these circumstances may have to navigate this over and over in a very hierarchical system with pre-existing complex relationships. I want to highlight this. This is a finding from one of the other students working with us, Rebecca Che, who found this statement from professional society guidelines, specifically talking about those leaving training and looking for jobs, and whether or not they should disclose or ask questions about workplace protections specific to caregiving. So you don't have to read this all. I recognize that's very dense. But what it really advises members to do is to avoid discussions of caregiving responsibilities that they have or that they anticipate, or even to ask about available protections in a hypothetical sense during the hiring process. I know that we've all thought about how to go through these circumstances or through these situations as they arise. And advice like this might be pragmatic. It's certainly easier to not talk about these things or ask about these things because you don't know what all the consequences could be. But when large organizations make these types of recommendations, it also increases the stigma, reduces psychological safety, and it risks exposing members of the group to unsafe work environments because they couldn't do due diligence. So caution against about these blanket statements about what people should or shouldn't do. So of course, this is a Penn audience. There's lots of different guidelines that apply to Penn. First, though, recognizing that members of the community practice in different states, all under a federal umbrella, different parts of the university, different schools. I mentioned the GME policies. Different departments have, as we've shown from the survey work, have different policies of their own and different understanding or application of the policies that do exist. Differences across medical centers and care environments, and even within the faculty practice group, members of outpatient services and inpatient services have some differences in policies and guidelines. So a lot has changed at Penn. We want to highlight the great work of the Penn Women in Cardiology group, which we'll highlight a little bit further, but they were a specific driver of guidelines and expectations for breastfeeding mothers that led to an update in the lactation policy through CPUP. At present, this only applies to those working in outpatient settings, but it allows both reductions in clinical effort and prescribed times for lactation during a busy clinical day. This is more opinion than evidence, but Quiva and I have thought really carefully about how leaders and departments can make this process better or worse. And overall, thinking about for the leaders in the room, people who care very much about this issue, have signed up for this session, we know that there's lots of good and bad practices that lead to a setting of psychological safety in some of the operational structures that can lead to retention or attrition in the groups that we have. I had a conversation with someone yesterday in which they had to remind a supervisor that they should not have their pregnant belly touched. So as much as we think there's good things happening and there's lots of people, lots of champions in this space, lots of work to be done. And especially for those without direct personal experience, or even those who have direct personal experience. You may have been pregnant, you may have had children, but if your pregnancy wasn't exactly like someone else's, it's really hard to translate your own experiences to a different generation, a different setting, different family structures that can make these experiences difficult and impactful in different ways. So as much as you can ask, read, engage, promote, discuss, and embody, the more likely that we'll see the culture change that we hope for. We want to recognize the work that Focus has done in terms of fostering collaborations. They've directly put us in touch with lots of good stakeholders, people who have done really great work on campus and off, helping to collate some of the resources. I mentioned that session with Dr. Bellini, informing some of the policies in the medical school. We have a dream that someday Focus could offer consultation services for departments who are looking to revise and change their own policies, both for best practice and evidence, and individual faculty navigator tools to figure out what applies and doesn't apply at different stages of a career. So what are we going to do? Our leadership survey remains open. So if you are department chair, division chair, GME leader, have a stake in running your department or your division and want to respond to our survey, we appreciate you. We are developing an individual survey for individual faculty members, seeking members of department champions who would help with distribution and specialty-specific development. Our own Women in Anesthesia group is working to update our own department guidelines. As we mentioned, the systematic reviews are in process, and planning to work with some of the Penn Law faculty to help develop a perspective manuscript on how employment law does or doesn't apply to physicians, dentists, and other health professionals. So we're hoping for the last bit of the session to talk specifically with you and members of the community about available resources, both using that facilitator and barrier framework at Penn. So in addition to the things that we've highlighted, the Penn Women in Cardiology and focus group, identifying that there are promotion-specific accommodations. There are specific leaders with titles encompassing a lot of this work, like the CHOP Director of Physician Wellness, recent lactation space initiatives, benefits for reproductive endocrinology treatment, and things like emergency backup childcare. The challenge is that this falls under a lot of different umbrellas. We're happy to share what we know. We'd also be happy to hear from the group different experiences or resources that have really helped facilitate your personal journey or have facilitated growth within your departments.
So if we